Okay, hi, this is Elliot Fishman, and welcome to our annual or weekly Wednesday Facebook Live. And the title this week was What I Learned Last Week at Our CME Meeting. Some of you, not enough of you, were at our CME course in Orlando this past weekend, 16th to 19th. And I will say, I'll give a plug, May 5th to 8th, we'll be in Nashville. Oh yes, here's our brochure. It's online, it's on CT as Us. Use my name, they'll give you a $10 discount or something. So we had terrific speakers, but I thought I would just cover some of the things that our visiting professors did. And just tell you a little bit, I'm not going to show you the slides. You had to come to the meeting to see the slides. But Alec Megabo, who's professor of radiology and surgery at NYU, who's a real expert in body imaging, spoke a lot about dual energy imaging. And Alex is a big proponent of dual energy imaging. He has dual source scanners, and he uses them routinely. I think many of us use certain select dual energy applications. I kind of love bone removal, particularly for vascular imaging. We do dual energy for gout and several other things. Metal reduction, we do dual energy. But Alec uses it for across the abdomen, across all applications. And some of the things he says, prerequisites for successful dual energy, technologists are critical. They take time to position patients, understand reconstruction techniques and appropriate kernel use, understand the local image network, and are familiar with department standards of image quality and radiation dose. And his feeling is that you can get really good enhanced iodine signal. You can do really good monoenergetic imaging, which can be helpful for metal reduction. Also improves image contrast, particularly with poor injections or low volumes on CTA. He talks about bone removal, characterization of renal calculi, and finds that things like virtual non-contrast, which is somewhat controversial perhaps, works out very nicely. And so they're using it routinely. And he says the radiologists besides him may not be that enthusiastic about it, but everybody kind of puts up with it. He says perceived impediments to dual energy imaging, images are not as good. It slows a busy practice, too many images on PACS, lack of workstation familiarity, no trust in quantitative data, and increased radiation. And his point is all of those facts are things that people say, but essentially all of those facts are truthfully not correct. Now, Alec then also spoke about CT-urography, and he talked about their technique is giving 1,000 mLs of water over 60 minutes. Patients are then asked to empty the bladder, then place an IV, give the patient butinamide prior to localization, then doing the non-contrast study, administering the dilute IV, 200 ml IV at 4 ml per second, and then administering saline. Now, I have to admit, he showed good images, both for transitional cell detection as well as other applications. Made the point you get good visualization of the pelvis and bladder and things aren't too dense. We've also, do a lot of CT urography. I like, obviously, a lot of water, but I don't do split bolus and I don't give any Lasix or anything else. And our images, I think, with post-processing come out equally well. So it's an interesting technique and some people do use it. He showed some very nice examples. So it is one of the ways of doing CT urography. So it is something that you can consider. He also spoke about CT enterography and talking about some of the indications and contraindications for CT enterography, speaking about, everything we know that it's very good for looking at inflammatory disease. It's very good for working on patients with abdominal pain that's unexplained, ischemia, particularly chronic ischemia. Talked about different contrast protocols, spoke about the fact that there's a new article coming out, and in fact it came out yesterday in Radiology, talking about the use of CT enterography in Crohn's disease patients, talking about some of the findings in Crohn's disease patients, and how CT enterography is very good for looking at things like strictures and ulcers, as well as looking at disease activity. And that's something we've spoken about on CT as Us before as well. So I think it's a very, very good article. He mentioned, of course, also detection of small tumors. He mentioned doing CT enterography using dual energy, and had good results there as well. And again, a critical thing, particularly in younger patients, is making sure the dose is low enough. So those are some terrific talks by Alec. One of his colleagues, Jill Jacobs, who's professor of radiology and head of cardiac, was also there. Jill spoke about a number of different topics. She spoke about vasculitis, which is a topic not many people speak about, but it's an important topic because we are seeing more cases of vasculitis. She went through some of the different classifications, the Chapel-Hill consensus categorization of large vessel disease, medium and small vessel disease, as well as variable and vasculitis with systemic disease. The key ones for large vessel are giant cell and Takayasu's, polyarteritis nodosa, and Kawasaki's fit in the medium vessel category. She showed some of the findings. Large vessel disease typically involves the aorta and its major branches. And again, it's a matter of not just looking at the axial imaging, but looking at the post-processing, looking for ulcerations, looking for wall thickening. Again, for something like Takayasu's, the left subclavian artery is the most common place to look at this. So it's important to visualize there. She also made the point that in coronaries and grafts, you can see issues, particularly with processes like giant cell arteritis. With Takayasu's, which is something we think more about, concentric mural thickening of the involved arteries as an early stage disease, and late stage stenosis, occlusion, or aneurysm dilatation, and associated with mural thickening, are things that you're going to see commonly. And Jill showed a lot of excellent examples of that, as well as medium vessel disease, as I mentioned, Kawasaki's, which is, again, a disease of younger patients, usually children under 5. But we see it in older children as well as in adults, the importance of multiple coronary artery aneurysms. She also mentioned something we forget, polyarteritis nodosa, which is systemic illness characterized by necrotizing inflammation of small and medium vessels, more common in middle-aged men, with fever, weight loss, and polyarthralgia as a classic presentation. And what you see, particularly is in the kidneys, infarcts, microaneurysms, and indistinct cortical medullary differentiation. And she showed some very nice examples. A key finding, of course, may be infarcts. And that's something to look at. She also spoke about Behçet's disease, where we think about at times small bowel involvement. The vascular involvement occurs in up to 46% of cases, may affect artery and veins of any diameter. Venous manifestations are more common. Most common cause of pulmonary artery aneurysms is Behçet's disease. And with Behçet's disease, the frequency of rupture is indeed very high. And she showed some very nice examples looking at vasculitis. And again, we spend a lot of time looking at vessels. We look at the aorta, we look at the key vessels, but often don't think about vasculitis. Jill also spoke about coronary artery disease and the role of CT, showing the value of CTA and the importance of understanding how to do post-processing in that scenario, ranging from MIPS to curved planar, to cinematic to automatic segmentation. She spoke about some of the challenges, both in terms of performance of the studies, as well as interpreting the studies, the importance of recognizing the role of calcium scoring, but at the same time understanding the limitations of calcium scoring. The accuracy of CT compared to CAF was discussed, and some of the advantages of CT as a low-cost, non-invasive, very accurate modality is something that Jill went over. She had a lot of really good references. She spoke about limitations. The typical one, besides an uncooperative patient, would be extensive calcification in the coronary arteries. So that's something we all know there's a problem to. Dual energy isn't that helpful at this point. She spoke also not so much about the vessel only, but to look at the identification of the vulnerable patient. What patients are more likely to get infarcts, which plaques are of greatest concern. And she also went into some of the newer things like functional flow reserve and really where that sits in terms of imaging. So this idea about CT being a one-stop shop Things like FFRCT and myocardial perfusion, DCT and spectral CT are all coming along. And the question is, where is that going to play? What kind of role? And how it's going to make us even do better? And this flow reserve thing is something that is coming along pretty quickly. So it's something that I think we all can think about. Now, the third speaker we had from outside was Charlie White from University of Maryland. Charlie gave a number of excellent talks. One was on the solitary pulmonary nodule. He spoke about the current status of screening and the role of CT. He also spoke about protocols, low-dose screening, 70 to 120 kV, 40 to 80 MAS, 1 millimeter thick sections every 1 millimeter. He spoke about the importance of post-processing and off-axial reconstructions, as well as value of things like MIP for detecting and defining the presence of small nodules. Charlie also made the point about the appearances of lesions, be they hamartomas or solitary pulmonary nodules that are malignant. He spoke about the different tumor types and location like carcinoids, centrally located. He spoke also about the Fleischner Society of subsolid nodule classification, how we look at those lesions, how we manage those lesions. He talked about the fact we don't talk about BAC anymore, but we talk about a whole different categorization from atypical adenomatous hyperplasia to adenocarcinoma in situ, which was actually the former BAC. It's minimally invasive adenocarcinoma, invasive adenocarcinoma to invasive mucinous adenocarcinoma, which was formerly BAC. So he went through many of those. He talked about some of the new techniques like CAD or vessel subtraction software, things that can be helpful for detecting lesions, but also evaluating lesions. Spoke about some of the new Fleischner criteria for 6 millimeters, spoke about some of the risk stratification, and again, the importance of keeping up with the newest technology, but also the new classification so that we look smart when we're speaking to our referring physicians. Charlie also spoke about high-resolution disease, gave a talk on idiopathic interstitial pneumonias with their classifications, again changing, and went through some of the different things we could see. Acute interstitial pneumonia, which is an ARDS-like but no known cause in the acute stage. Over time, there's more of an organizing phase. He went through some of the changes to expect in terms of the infiltrate pattern in acute interstitial pneumonia with the extensive involvement, lack of pleural effusions, lack of consolidation, involvement of upper, mid, and lower lung fields very commonly. He spoke about things like cryptogenic organizing pneumonia or COP, patchy infiltrates, 90% lower lobe predominance, periphery location in up to half of the cases, spoke about its association, for example, with collagen vascular diseases. So, and he showed some very nice examples, which I'm looking at right now, which you can't see because you weren't at the meeting, and I'm looking at the syllabus. And I can't post the syllabus because it was only for people at the meeting. So, if you know someone who was at the meeting, maybe you can look at their syllabus, which will be up online for another 7 days. He also spoke about pulmonary fibrosis or UIP, predominantly baser and subpleural, talking about things like IPF and collagen vascular disease, asbestosis, and then some atypical patterns like drug reaction, hypersensitivity, pneumonitis, and sarcoidosis, to name a few. And it was a really excellent talk talking about some of the smoking-related processes as well. Charlie also spoke about interstitial lung disease in the sense of looking at a pattern approach, thinking about the interstitium, thinking about the secondary pulmonary lobule, thinking about the anatomy of the lung, about disease patterns from cysts to nodules to lines to air spaces. And he went through many of the different patterns, be it emphysema or Langerhans cell histiocytosis, or LAM, lymphangioliomyomatosis, or LIP, lymphocytic interstitial pneumonia, and also some of the recent work on Birt-Hogg-Dubé disease. Again, emphasis on high-resolution lung CT and the specific patterns. Again, with high-res lung, there's lots of overlap, but as Dr. White suggested, there's an understanding of distribution, upper-lower, the cystic spaces, how the bronchi look. For example, LAM, diffuse distribution, multiple 5 mm thin-walled cysts, nodules rare, pneumothorax not uncommon, and chylous pleural effusion. So we also had Karen Horton speak about deep learning, and Karen also spoke about improving your practice, as well as pancreatic masses and small bowel obstruction. We had Stefan Zimmerman speak about pre-op and post-op evaluation of aortic aneurysms, both thoracic and abdominal, as well as the role of CT these days in TAVR. And I gave a number of talks, from protocols to 3D imaging, to adrenal, to renal masses, to small bowel tumors, and a few others. So it was a successful meeting technically and everything. In terms of the quality of the presentations, I sat there for all the talks, and I will tell you they were across the board uniformly excellent. So if you weren't there, you missed a great opportunity. We also had great weather. It was 85 degrees every day in Orlando. But with global warming, the weather in Orlando seems to get better. But hopefully I gave you some facts and some stuff of what you were looking at. Let me just see any questions. I guess you can't really ask questions because I was more or less telling you what we saw and what we discussed. It's also a good opportunity to think about what's important in terms of imaging. And again, it's important to tell you to go to meetings. Meetings are very critical. 4 or 3-day meetings for learning is really an important experience. And at CTisus, we provide a lot of information for you, but we think the meetings are also very, very important. So hopefully we'll see you at a meeting. And with that, my time is up, and I'll see you next time.